A very good afternoon and a warm welcome to today's NITRD CTD NTF Difficult to Treat TB Clinic. On behalf of NITRD, it is my privilege to welcome our DDG Sir Dr. R.P. Joshi and his team, directors and team from NIIT, NTI, STOs, directors of STDCs, faculty of medical colleges, DTOs, medical officers, all the participants who are attending today's clinic. Introducing the faculty from NITRD, I myself, Dr. Saroj Meena, pulmonologist from NITRD. On my right is Dr. Rupak Singla sir. He is HOD, TB and RD. Today, our director sir, he is on work travel. So I request Dr. Singla sir, HOD, TB and RD, to give his introductory remark for today's clinic.
Thank you, Dr. Saroj. On behalf of NITRD, we welcome all of you for this today's difficult to treat TB clinic. As you are all aware, we started this clinic at the national level, and our aim was that each state should run their own individual state level difficult to treat TB clinic. Idea is to have capacity building of all the doctors of the country. And it's a good news that today, out of 36 states and union territories, 29 states and union territories, they have their own difficult to treat TB clinic. And we are there to hand over them whenever they need it. And we are all aware that each state has its own problems, has got its own solution for this. So we request all the states one by one to present their interesting case and discuss with the rest of the country so that we all learn from each other. Today, we are having the presentation from the state of Telangana. And this will be another thing this will be not only pulmonary, this will be extra pulmonary involvement also. So that will be the add-on thing. And this has been the request of the participants also that we need to discuss pulmonary as well as the extra pulmonary cases also. So with these few words, I welcome you once again on for this difficult to treat TB clinic. And I'm sure this clinic will again be enriching our knowledge about the management of tuberculosis and pulmonary and pulmonary. So with these few words, I hand over the stage to Dr. Saroj Meena. Dr.
Thank you, sir. And now I request our DDG sir, Dr. R.P. Joshi, to give his address.
Namaste. Thank you, madam. Namaste. Good afternoon, all. A hearty welcome on behalf of CTD to all the experts, the NTF chair, Ashok Bharadwaj sir, NITRD senior colleagues, and the Telangana state who is making a presentation here, and all the participants. See, NITRD has been a pioneer in this difficult to treat clinics, and I congratulate the team for taking this forward, and also say that it has been scaled up across the country. So this is a very good opportunity for all of us to learn from each other, learn from the experts, how to manage difficult to treat TB clinics. Tuberculosis, even though it is the organism was identified long back, it has got such a myriad of presentations that it is not easy to diagnose, not easy to treat in some cases. So I thank all the faculty members and the experts for guiding us in this regard. So I wish the clinic all the best. Thank you.
Thank you, sir. Thank you, sir, for your kind words. Now, moving on to today's case presentation, as told by Dr. Singla sir, that these clinics are run by rotation basis from different states. So today's session is from the state of Telangana. Dr. Shravya, consultant Little Star Children's Hospital, Panjagutta, and Dr. Sunita Reddy, ID consultant, infectious disease consultant, they have worked up the case. Dr. Shravya will be presenting today's case. The DRTB center associated with this is Apollo Hospital, Jubilee Hills, Hyderabad. Today's state expert for the session will be Dr. C. Sumanlata. She is an epidemiologist, STDC, MD Pulmonary Medicine, Civil Surgeon, and Specialist, Telangana. The national expert for today's session will be Dr. D. Bhera sir. Sir needs no introduction. He is the Padma Shri awardee and currently an emeritus professor at the Department of Pulmonary Medicine, PGIMR, Chandigarh. Now I request Dr. Shravya to please start with the case presentation. Over to you, ma'am.
Good morning, everyone. So today we'll be discussing regarding the case that we have come across. So we have been dealing this case since last year. I would like to start with the definition for disseminated tuberculosis. It is defined as a presence of two or more non-contiguous sites that is resulting from hematogenous spread of Mycobacterium tuberculosis as a result of primary infection, which can also be reactivation of the latent focus with subsequent spread. Usually nail involvement will not be seen, except that all the organ involvement can be seen in a disseminated tuberculosis. So we had come across a child, baby S, she's an 8-year-old baby, born out of a non-consanguineous marriage and third in birth order. Her major complaints were abdominal pain for 10 days, which she came to the hospital with, and bilious vomiting and abdominal distension for 6 days. So we had gone through a detailed examination, and we have took a detailed history. So the presentation was abdominal pain, and in the week 1 of presentation, she had gone to another hospital for evaluation. She has been admitted there for 5 days, from where she was referred to us. And she had got a CECT abdomen done there at the referring hospital, where there were multiple air fluid levels and signs of perforation were noted, and surgical intervention was planned. But the child was hemodynamically stable, so they did not perform the surgery immediately, and she was referred to us in terms of some financial constraints she had come to us. So we took a detailed history of her, where it was noted that she was having fever since 3 months, which was high grade, no nocturnal variation, but it was associated with some night sweats and weakness. Whenever she had the fever, the febrile period was presented with weakness. So, there was significant weight loss, which was approximately 20% in the past 3 months, and also decreased appetite for a week. So we wanted to further evaluate completely the child. On general examination, the child was looking malnourished, and she was sick looking, but hemodynamically stable. Her weight was way below the 3rd centile. So we took a detailed examination, and we evaluated all the systems. A chest X-ray was showing pleural effusion and perihilar lymphadenopathy was present. Then in view of abdominal distension, we had done the CECT abdomen again to reconfirm if there was perforation. There were hepatic nodules that we have come across, and multiple air fluid levels were there, where we thought peritonitis and perforation could be the cause for it. But as the child was hemodynamically stable, we considered it to be subacute. And cardiovascularly, she was hemodynamically stable. Her BPs were normal, but as a routine procedure, we had done a 2D echo also, where we have noted there was mild, moderate pericardial effusion and circumferential pericardial thickening, but there were no signs of tamponade. And in view of bloods, all her LFPs, RFPs were normal, but there was anemia that was noted. So there was multi-system involvement, and this is the chest X-ray of the child, which was suggestive of consolidation, and pleural effusion was seen on ultrasound, not on the chest X-ray. Minimal pleural effusion was there. This is the CECT of the child, where there were free fluid levels and multiple hepatic nodules. So here we had multiple possibilities. So we were thinking, what could it be? Is it severe gram-negative infection, or is it just intestinal obstruction with peritonitis and multi-system involvement? So we kept the child NPO initially in view of her abdominal status. And should we start, we have already sent all the bloods gene expert, and we had multiple consultations with the ID specialist, pediatric gastroenterologist, and pediatric surgeon. So a multidisciplinary approach was considered, and we were still in doubt to start ATP or not, because the diagnosis has not yet been confirmed. As we have sent for the gene expert, we have sent gene expert from the sputum and the gastric aspirate as well. Meanwhile, as the child was weak and malnourished, and we could not start her anything orally in view of her bilious vomitings and her subacute peritonitis status, we have started her on TPN. So here we have come across the diagnosing difficulties. We have sent 2 samples of sputum and 2 samples of gastric aspirate for gene expert, where MTB was not detected. In view of strong suspicion of tuberculosis, tissue diagnosis was considered, as she had hepatic nodules, and we also thought of EBUS, CT-guided EBUS, and discussed it with the parents as well, and discussed it with our gastroenterologist and pulmonologist as well. Because the parents were not willing, we couldn't go ahead with the EBUS, and we thought we would wait for the tissue diagnosis. We would wait for the gene expert rather than the tissue diagnosis. We had sent 3 samples of sputum and 3 samples of gastric aspirate, where the 3rd gastric aspirate was detected with Mycobacterium tuberculosis. Low detection was there, and rifampicin resistance was not detected. So we thought we can go ahead with the ATP, but meanwhile we have started the child on piperacillin tazobactam in view of her abdominal status. IT was also sent at this point. In view of disseminated spread, we thought about primary immunodeficiency as well. As TB is endemic in India, primary immunodeficiency and TB could be seen as a relation in endemic areas. That is the reason we have considered primary immunodeficiency workup as well. So where are we heading here? We are not very sure if we can start the IV ATT. So as after consultation with the infectious disease specialist, we have started the IV antibiotics as per 2nd-line ATT regimen. So we have started her on levofloxacin, linezolid, and amikacin. Meanwhile, the abdominal status of the child remained the same. This was 5 days after admission, where we have started the 2nd-line ATT. She was still NPO, and she's still on TPN. So conservative management was being continued. And after the child was started on 2nd-line ATT, she became fairly better. She started passing stools, and there were the bilious aspirates were also coming down. So persistent air fluid levels were present on the X-ray despite continuing the treatment. And even though the child remained hemodynamically stable, we had multiple discussions over here for the first 1 week, whether to operate the child in view of her gastrointestinal status, in view of her intestinal obstruction. But because she's hemodynamically stable, and in view of TB, in view of adhesions, considering the further future risk of adhesions, initially we couldn't go ahead with the surgical aspect, but as the child was persistently having multiple air fluid levels on X-ray, and the bilious aspirates were continuing despite starting 2nd-line ATT, they have come down in view of the quantity from the beginning, but as they were still present, we wanted to go ahead with a diagnostic laparoscopy. So with the help of a surgical pediatric surgeon, we have gone ahead with the diagnostic laparoscopy, and to our surprise, there was a large loculated abscess with 700 ml of pus that we had to drain, and an abdominal drain was placed. There were very dense interloop adhesions. So this pus was sent, this was the X-ray. These were the serial X-rays that we have taken. So despite the pus that was drained, we have sent for the gene expert and as well as the pus culture. So coming to the cardiovascular aspect, as there was pericardial thickening and was noted along with no signs of tamponade, serial 2D echoes were done. Progression of pericardial thickening was noted and steroids were planned. HRCT was also planned to assess the thickness of pericardium, and we have explained the procedure for pericardial stripping to the patient as well. The pus that was drained was sent for gene expert, and it revealed Mycobacterium tuberculosis, and rifampicin resistance was not detected on gene expert. The pus culture has revealed Klebsiella sepsis. So in view of Klebsiella sepsis, we have started IV meropenem and we have given that for 2 weeks for the child. Gradually, the child had tolerated oral feeds. IV methylprednisolone was started after treating sepsis for pericardial thickening. Oral ATT was started 1 week prior to discharge and she had tolerated well. So the child tolerated oral feeds well after the second line ATT was started and the abdominal infection was treated, and after the steroids were started, she was tolerating oral feeds well. Oral ATT was also started on week 3 of admission, and we have put her on HRZD regimen, which is an 8-month regimen, 2 months of intensive phase and 6 months of maintenance phase with 2 months of steroids. These are her lab values that were done during the course of hospital stay, where initially she had anemia after starting the IV antibiotics and IV second line ATT, and there was an improvement with her bloods as well. Her LFTs and RFTs remained normal throughout, and electrolytes were also remained normal throughout the course of hospital stay. So she had regular follow-ups. She was put on oral ATT. She had regular follow-up with us and with the ID specialist and cardiologist in view of her pericardial thickening. The clinical improvement was seen. The child was very much improving well developmentally, and she was very active. She got back to her normal work, her normal studies and all that. So the child tolerated medications and oral feeds also well. Her appetite increased, but as the thing that we had noticed was there was no weight gain per se. But as the child was clinically improving well, we had continued the same treatment. After 2 months, the child presented to our OPD, to our ER with seizures, and after tapering and stopping steroids. We had stopped steroids 2 days prior to that, and to our surprise, she had presented to us in the ER with seizures. So we admitted her and started on IV antiepileptics. Possibilities of tubercular meningitis or tuberculomas was considered. Bacterial meningitis was also considered as a secondary infection could be possible in case of tuberculosis. And we have also considered immunodeficiency here. So is this because of after stopping steroids we had seen this? Is it because of iris, or is there any drug resistance, or because of her abdominal status that we had previously, her peritonitis and subacute perforation? Is there any poor drug absorption? These were the things that we had in our mind. So we had to further investigate the child. MRI brain was done after she was stabilized, which was suggestive of TB meningitis. And MGIT culture, there was growth of Mycobacterium tuberculosis was present. So we had multiple discussions regarding this with the ID specialist, and LPA was sent for second line ATT. We wanted to send LPA for both the first line and second line ATT, but as the parents were not very cooperative for that, we had to send only for the second line ATT, and whole genome sequencing was requested and sent from our side. So this was the MRI that was done for the child. where she had tuberculomas and meningitis features also, tuberculous meningitis features as well. So the child was with us, and we had again evaluated her top to toe, where 2D echo was repeated and minimal pericardial effusion was there, which was on the decreasing side with no features of pericardial constriction or tamponade. And LPA for second line drugs was sensitive. Cycloserine was started in view of good CNS penetration as the child was having tubercular meningitis. So this was the second line LPA for second line drugs, which did not detect any resistance to the second line drugs, injectables. So she was improving with the IV antiepileptics and the IV ATT that we have started. But on the second week of admission, we noted that the child was having severe abdominal pain and did not pass stools. She was kept NPO. High dose of steroids was started, IV methylprednisolone was started, and we consulted a pediatric surgeon where again her serial x-rays were done, where there were multiple air fluid levels and intestinal perforation was again suspected. So a surgical intervention was planned. Parents refused. Here the child was still hemodynamically stable. The parents refused, went to another hospital, got managed conservatively there, and had come back. So they were continuing the IV ATT, IV linezolid and IV amikacin while they were at the other hospital as well. These were the lab values during the second admission, where the hemoglobin was normal and LFTs and RFTs were normal. So after 2 weeks, when she had recovered and her oral intake was good, she was started on oral steroids, where she was on IV. We have shifted her to the oral steroids and regular follow-up was done. She was being continued IV ATT even after discharge. So for 2 weeks, we have continued the IV ATT and then restarted her on oral ATT after 2 weeks of discharge, where consistent weight gain was noted during the follow-up. So the genome sequencing report had not come by the time we had discharged her. After 2 weeks of discharge, we have the genome sequencing report had come in, and to our surprise, it had resistant to the first line drugs of ATT and the second line drugs, that is 1-fluoroquinolone and injectables as well. So we had to consider the diagnosis of extreme drug resistant tuberculosis here. So this is the whole genome sequencing that we had sent for, which had shown resistant to the first line drugs, to the fluoroquinolones and injectables as well. So the child was being followed up constantly from there, but as the child had shown improvement in terms of growth, in terms of her well-being, in terms of the nourishment, we had to continue the oral ATT, which was compliable to the child. The child had not shown any signs of side effects to the drugs as well. So we were continuing oral ATT, and during the regular follow-ups, the child is being followed up monthly regularly. We have not noted any signs of other dissemination of the tuberculosis that was there. So we are continuing the same line of treatment. And recently we have done a MRI in September of 2022 to decide upon the duration of the treatment. So the MRI was suggestive of significant resolution of the intraparenchymal lesions, but there were tuberculomatas that were present. Multiple tuberculomatas were present, but the number had decreased comparatively from the first one. And the ventricular dilatation, which was seen on the first MRI, there was a resolution in comparison with the first MRI. So pulmonary wise, we have done a HRCT and no parenchymal lung abnormality was seen. Cardiac wise, we have done a 2D echo. There was no effusion or pericardial thickening. And GI wise, we have done a repeat CECT abdomen which revealed residual hepatic granulomatous and multiple mesenteric lymph nodes. And ophthalmic evaluation was also done. Fundus evaluation was normal. Growth was acceptable and fair in terms of height and weight. So this is the repeat MRI that was done for the child. There was a significant improvement in the growth, even though it was below the third centile initially. The weight has come nearly to the 50th centile now, currently. So we are continuing the same treatment for the child, that is the oral ATT, apart from the second line ATT for her. Currently, she is on HRE, with the 3-drug regimen, and repeat imaging is planned 18 months after the ATT.
Thank you, Dr. Shravya, for the excellent case presentation. I'll summarize the case for those who have joined late. So this is a case of an 80-year-old child who presented with a disseminated tuberculosis of lungs, pleura, abdomen, and CVS in the initial presentation. Diagnosis was made from the biopsy done from the hepatic nodules were present on CT abdomen, and the biopsy was done from hepatic nodules, which shows MTB detected. And patient, in view of subacute peritonitis, initially patient was kept NPO, and total parenteral nutrition was started on the patient. And after the diagnosis, the patient was started on second-line injectables consisting of levofloxacin, linezolid, and amikacin. And meanwhile, patient, in view of disseminated COX, patient was also started on IV steroids. Methylprednisolone was given to the patient. Once the patient improved and started tolerating oral feed, patient was switched to the oral therapy and oral steroid, and patient was discharged. But unfortunately, patient was presented again after 2 months with seizures. And again, the diagnosis was reviewed again, and MRI brain was done, which was suggestive of TB meningitis. CSF fluid was done, in which shows MTB detected, and LPA was also done, which shows sensitive for the second line TB drugs. In view of the CNS tuberculosis, the team started the patient along with the IV injectable ATT, levo, linezolid, amikacin. Cycloserine was also started. Patient again improved in the admission, and after stabilizing the patient, the patient has been discharged, and the IV and ATT was continued for 2 weeks after the discharge also, and thereafter the patient was switched to oral regimen. Meanwhile, they also did gene sequencing, which revealed resistance to HRE, first line ATT, fluoroquinolones, and amikacin. So with that, patient was, we can diagnose XDF-PTB. But because the patient was showing improvement in clinically, weight gain was there, and there was improvement in tuberculoma. There was improvement in pleural effusion. The pericardial effusion was also improved. So the team continued the drug-sensitive regimen only, along with the steroids, that is HRE. Currently, the patient is on HRE, and patient is improved. That's the summary of the case. So, any questions from the participants?
Singla, may I come in?
Yes, sir, please.
I think case was very interesting, and let me know from where this which lab gene sequencing was performed, because that has shown quite entirely different result. So I would like to know it was from which lab?
Sir, it was done from ThyroCare. They had sent it to Mumbai and got it done there.
So ThyroCare, I know that they are doing gene sequencing.
Yes, sir. And we have actually also considered to repeat it because the child was improving for the first line ATT. And
Right.
as after we had the nodal TB conference during the first session, the state conference, we had a discussion, and it was suggested to repeat the genome sequencing so that to cross check it. but
Yes,
there was only 1 ml of sample that was left, and it is a little time taking process, and the parents were also not willing. The first report was also done from the hospital side. The parents were not willing for the test.
but my understanding is that as a clinician, we see many times there are difference in the results of various tests.
Yes.
So gene sequencing is still, I think, in the country has not been very clinically well related. And I agree with you that this case, when patient is improving with the finally as a primary line of drug, and so we should continue this. And probably we have to ignore the gene sequencing result. This we do as a clinician, we have to face such situation many times.
Yes.
And that was the one. But one more point as it was a case of very clear, it was a case of a disseminated tuberculosis. I was little probably steroid was started late, because one of the indications for steroid in disseminated tuberculosis, especially in a low general condition, when the child presented in a very low general condition, the steroid should have been started from very beginning, when covering all the aspect of infection, whatever infection, whether it was a pyogenic or tubercular, because in disseminated tuberculosis, steroid helps, no doubt about it.
Yes, sir. In view of her peritonitis and we had Klebsiella sepsis, we had to delay the part of the steroid a bit in view of the Klebsiella sepsis.
Right. Maybe because of the secondary infection. Because as a clinician, I always say that every time labs may not be sacrosanct. Many times we have seen that lab results may not be as sacrosanct as it could be, and it also depends from lab to lab. So anyhow, but good news for this case, I must compliment that ultimately the child is improving, and with the primary line of drug. Thank you.
Thank you, sir.
Yeah, Dr. Singla, may I come in?
Yes, sir, please.
Before I give my comments, I just want, because somehow I got little confused. Can you just tell us what are the drugs the child altogether has received? Can you give a consequence?
Sir,
Can you give a sequential? Can you tell sequentially how long he received injectables, when it was stopped, and then what is going on now? Can you give a entire treatment summary?
Sure, sir. So last year, February, she had been admitted with us, February 25th, where initially, before coming to a conclusion of tuberculosis, as she had peritonitis, we had started her on IV piptaz, piperazine tazobactam, which was given for 5 days. And later, we have continued with the IV ATT after sending the gene expert for the sputum and the gastric aspirate as well. The
IV ATT means what? Which are the drugs?
Linezolid, levofloxacin, and amikacin.
Okay.
These were given, and as in week 2, that these were being given for 1 week, and after 1 week, where it was found out to be Klebsiella sepsis, Klebsiella peritonitis, we have given meropenem as well for 14 days. And after that, we have continued the IV ATT for 1 more week. So she had received a total of 3 weeks of IV ATT. And then before discharge, we have changed her to oral ATT, HRZD regimen. And she was discharged with that, and she was being continued for 2 months with HRZD and oral steroids, which were tapered and stopped. After stopping the oral steroids, 2 days after stopping, she had come back to us in March, 13th of March, and with her CNS tuberculosis. There we have started her with IV antiepileptics, that is initially midazolam infusion she was on, sir, at admission. and she was also receiving levetiracetam, IV levetiracetam. So currently she is taking levetiracetam as well, oral. And from there we have, in view of her oral ATT were being continued, but as she had developed abdominal distension again in the second week, we have again restarted her with linezolid, levofloxacin, and amikacin. We have added cycloserine here, which was in March, that is 18th of March last year. We have added cycloserine as well. And in view of CNS penetration, she was continued IV ATT for 2 weeks. After 2 weeks, we have restarted her on oral ATT HRZD regimen. So she had received HRZD regimen till recently, that is till August of 2022, and after the MRI was done in September, we have shifted her to HRZD regimen, 3-drug regimen. So till September, she was receiving 4-drug regimen, HRZD oral, and steroids were tapered after the MRI was done. She has received a total of 3 months steroids after the second admission.
Okay, thank you. Dr. Rajendra Prasad sir, do you think any comment about the regimen?
Well, Dr. Behra, child was very sick to begin with, and lot of abdominal symptoms and other things. So in view of that, ideally the second line drugs should have not been used in such cases, but since child cannot tolerate oral drugs, so they use the injectable, many of them are injectable. That was probably done because of the child is not feeding and child is not tolerating oral drugs. And we have hardly, and these were having some anti-tubercular properties. And ultimately, this has helped the child. So as a clinician, my viewpoint is whatever you do, it should be help the child. Otherwise, the second line drug might have not started to begin with, because there was no evidence of any drug resistance except the last gene sequencing report, which to me looks not very reliable, which is not clinically correlated. That was my comment, Dr. Behra. And ultimately, they shifted to whenever the child has allowed that oral drugs, now the child can tolerate, they have shifted to the primary line. So this much of little bit of deviation in the interest of the patient, in the interest of the life of the patient, can be done sometimes.
So
Yes, I think.
we'll come back to you, Dr. Vera sir. Let's go back to the participants. Dr. Padma, you've raised your hands. Dr. Padma Priya from ICMR.
Thank you. Thank you. So first, let me, like all others, I would want to congratulate the whole treating team for helping this child out. My only question to the presenter is, what about her immune status? Does she also have some other immunodeficiency that you mentioned briefly in your presentation? Just wanted to know that. That is question one. And the second is, why did you decide? I mean, like Dr. Rajendra Prasad said, child was not doing so well, so you had to put her on IV second line and then change it to first line drugs. So I just wanted to get some input into your thought process of why did you change from second line, started on second line and then changed to first line. Because throughout your presentation, you said the child was not sick at all. The child was stable in spite of you thinking of perforation. You said the child could not be taken for surgery because the child was stable. So the child was not very sick. I mean, maybe my understanding is wrong. So just these two questions for you, doctor. Thank you.
Dr. Sravya. Ma'am, are you there?
Yeah. Am I audible, ma'am? Sorry,
Yes, ma'am, please.
sorry. So the child was hemodynamically stable, but the child was having bilious vomiting. She was unable to take anything orally. She was very sick. In terms of hemodynamic parameters, she was stable. But the child was very sick looking. She was having severe abdominal pain. She was having abdominal distension, in view of which we couldn't give her anything orally. And initially we were having bilious of around 200 ml per day, which gradually decreased after starting IVA. Did I clear the question?
I hope that's clear, Dr. Padma.
Her immune status, doctor, I thought you said she had some, you were looking for other immunodeficiency because a child with disseminated TB. I don't know whether you had a history of contact from anybody or was it a primary immune deficiency, multiple immune deficiency. Was that looked at all?
Contact history, we have traced the contact history of the family. We have done the testing in the family, close family members as well, because the family, it was not a nuclear family, so we had to get testing for all the family members. And the neighbor contact history was also traced. We did not find any contact history as such, madam. And regarding the immunodeficiency part, we have considered primary immunodeficiency, but as the child did not have any infections prior to this, and the child was healthy prior to this infection, that is first 8 years of her life, she was healthy. She did not have any major infections, and there were no admissions as such, and the parents were not willing for the test. We couldn't get the primary immunodeficiency status done, but we have considered that. But clinically speaking, as the child was completely fine before 8 years, we have considered it, but we thought immunodeficiency might not be the cause for this. We have also done the HIV status, which was negative.
Thank you, ma'am. Ma'am, there are some questions in the chat box. We can answer there. And
Sure.
Dr. Jai Kishan sir has raised his hand. Please unmute him.
Hello, am I audible?
Yes, sir.
So my question here is that at the time, once the first was aspirated from the pleural cavity, Klebsiella was grown, that was found to be positive. So as per the policy of the NTEP, the first line LPA, the second line LPA, and even the IRL is supposed to go for the culture also for the extended test. So whether the first line LPA or the second line LPA and the culture was done at that time or not, and if it was there, then we could have found the additional resistance. And as far as the regimen is concerned, that linezolid, levofloxacin, and amikacin, usually we go for the streptomycin, ethambutol, and quinolones. Okay, so they are the drugs which can be given. Ethambutol can always be there in otherwise, but streptomycin, quinolones could have been given. Why the linezolid or levofloxacin, amikacin was started? Whether it was to cover the infection part as well, or only for the sake of the anti-TB drugs. Second, again on the second occasion, the second line LPA was sent. What was the status of the report of the LPA test done at the second occasion? So we have sent no doubt the whole genomic assays, but whatever is available under the program, under the NTEP, the first line LPA, the second line LPA, the cultures, whether they were tested or not, and what is the final status of these reports, whether they were sent one or not. If they were sent, then whether the results were tested or not, and accordingly the regimen was modified or not. Because at the early stage, if we are able to pick up the additional resistance, then we may not have to go for all these the increased morbidity and complications in a child like that. And although there is a difference in the vivo and vitro results, whole genomic sequencing, although not accredited by the NTEP, but the status of the whole genomic sequencing and results is being recognized by the other countries and by the WHO. So in that scenario, once we know that the patient is having the resistance to the isoniazid, rifampicin, and ethambutol, whether it will be prudent to continue with these regimens, and should we not give the benefit of the other drugs in under the program? That is what is my question.
Yes. So during the first admission, as the child had presented with subacute peritonitis to us, she was already started on linezolid, levofloxacin, and amikacin in the referring hospital. She was started in view of the peritonitis, and to treat any bacterial infection per se, she was started on that. So we had to continue that, sir. As rightly pointed out, LPA MGIT was sent. We had sent gene expert from the gastric aspirate and sputum, where we had received there was no resistance to rifampicin from the gene expert, and MGIT was sent. But as rightly pointed, we did not send the LPA for the first line and second line because the gene expert was clearly showing rifampicin sensitivity. We had to continue with the first line, and as the child had improved and we gave the oral ATT, we had put the child in the hospital for 1 week after starting the oral ATT. And as she was improving clinically, we had to continue that. In terms of the financial constraints, we couldn't send the LPA for the first line and second line, which was considered. We had that in the point of our discussion, but we couldn't send it. But as the child had come back to us 2 months later, and CNS tuberculosis was noted, we had the first line and second line ATT, where the parents were again not willing to send for the same. So from our hospital side, we had to send LPA for second line after multiple discussions with the microbiologist and the infectious disease specialist. We had thought, okay, as we had received rifampicin sensitivity in the gene expert, multiple gene experts, that is one in the pus culture that we have done and one in the gastric aspirate. As rifampicin sensitivity was present. So we thought we'll send it only for the second line LPA. So we had sent that, and the sensitivity was present. There was no resistance that was noted in the LPA for all the second line drugs as seen. I have also shared that picture in the presentation, sir, the LPA report that was there. So as the report is immediate and we can make some decision immediately, we had sent the same. And regarding the choice of antibiotics, we could have gone with the other antibiotics, but as we noted that the child had improved with the similar antibiotics in the first admission, that is levofloxacin, linezolid, and amikacin, and there could be, as we are giving linezolid, there could be broad spectrum coverage of the secondary bacterial infections also. We had continued the same antibiotics because we have already seen the improvement of the similar antibiotics during the first admission. We had given that for 2 weeks on OPD basis and then shifted her to oral regimen. And genome sequencing was sent at the same time during the second admission, which was not done during the first admission as we did not suspect any resistance to the drugs. We had thought only because of her abdominal status, she was unable to take oral. That's the reason we have put her in the first place in this for the second line ATT. And during the second admission, we had considered even drug absorption during the second admission. Because of her abdominal status, she had additions previously, and she had subacute perforation and peritonitis. Could there be any absorption issues? She was malnourished for a quite lot of time. So was there any absorption? Even this was considered. Gastroenterologist opinion was taken. But as the child had improved clinically for the 2 months that we had seen. We took a chance there. We had even also spoken to the Chennai Chennai center where they do the drug levels. So they asked us to send it after starting the oral ATT, not with IV. So after stopping the oral ATT, we had to send them. But as the child's clinical status deteriorated during the admission the second time, she again presented with peritonitis. We couldn't send that because we had already started her on IV ATT. We couldn't send the drug levels at that point of time. But later it turned out to be drug resistance, as we have seen on genome sequencing.
Rupak, may I come
there
two
is-
small comments, Rupak?
Can,
Yes, sir. Yes, sir. Then we would like, yes, sir, after your comment.
only small comment at this stage.
Yes, sir.
That probably LPA1, it is LPA1 is free in the program. So LPA1 could have sent, and the advantage of LPA1 could have been that if there is a resistance, of course there was no rifampicin resistance, that could have been detected, and that could have given some idea about the future line of management. But I totally agree with child is improving with these drugs. Always, as a clinician, I always say it is the final outcome. What is the improvement we have to look? But we have to be very careful because gene sequencing has already shown multiple drug resistance. So that also has to be taken up. And my vision is that child has to be under close surveillance and follow up what is happening. But good news that he is improving at present.
sir, what is there is, so in case the first line LPA had revealed the H resistance, then we could have modified the regimen one. And in case the H resistance was there, it will lead on to the amplification of the drug resistance. To in case the child was initial improvement should not be taken as the measure, because the initial improvement is bound to be there with the drugs. But later on the patient will develop the resistance, or the patient may have the relapses. So on that account, we should be picking up whatever the resistance pattern is there, and the program is offering the first line and the second line LPA at the earliest. Okay, that is what is I have to say. And that question remains, what program says that once whole genomic assay is available and is accredited by the non-NTP stakeholders, then in that scenario, whether it will be prudent to continue with the HR ethambutol once whole genomic sequencing is showing resistance to all these drugs.
So we can take the opinion from Dr. Suman Lata, the state expert of today's case, and she has been the pillar of this while treating this case. Ma'am, please your words and your opinion regarding these points.
Okay.
Yeah, good morning, ma'am, and thank you all. Thank you, Dr. Shravi, and thank you, NITRD, for giving us this opportunity. So this case, when we see in episode by episode or step by step, we are always in the crossroads. So when we know that we have multiple intestinal fluid levels, and we suspect some subacute intestinal obstruction. So there is a first crossroad whether we have to go surgical mode of management or a medical management. That is first crossroad we had. Second crossroad where we actually did not know was where she was not able to take oral drugs, and we don't have anywhere in the NTP guidelines also it's mentioned that when particular person is on NPO, how can we give the drugs? How can we administer first line drugs when we suspect or when we diagnose clinically the tuberculosis? That is second crossroads. And again, when we see the multiple organ involvement at that particular point, like her, she had pericardial effusion, also a pleural effusion, which involved lung component and also the heart component and intestinal component. So to see three systems involving, there again the role of steroids. How long should be these steroids given? That is another crossroad. And we being keeping the sepsis in mind, is it good to give steroids at that point? Another dilemma. So this was another crossroad. So here actually the team of Dr. Suntana Reddy and Dr. Shravya, they have worked step by step, meticulously looking very closely and seeing to the benefit of the patient. Here again, yeah, we miss the first line LPAs and other consequent DST tests. Then again, when the patient, when it came up after 2 months of using HRZD, again she had multiple lesions in the brain, again tuberculosis. Now there was a query where, was it an iris and was it a drug resistance, which is evolving. So we did not know what to choose. So that, I mean, to go ahead, we need to, take a clinical decision at that point of time, and then we have to go across. So there, in that perspective, when we go across, and we know we get a whole genome sequencing late, and when we continued with the first line ATT and continued with steroids, she was improving. So it proved that her first line ATT is the was the right choice of regimen. But here again, whenever she was not tolerating orally, we had to go switch to the injectables, and first line drugs, injectables are not available. So we are going to use the second line ATT drugs only as injectables in that point of time. And I think Dr. Suntana Reddy, who worked close with this case, will also add to my points.
Thank you, Dr. Suma. Thank you, National TB Program, for giving us this opportunity to present this case. As like Dr. Suma had mentioned, this was a young child, 9-year-old girl who was malnourished and who came to us in a very difficult situation with disseminated TB, where we could not give oral medications at all. So yes, it's not part of the National TB Program to give injectables initially, but we just went ahead with all injectable regimen because we didn't have much of a choice. We had to get the child get better. We can't depend on oral medications at that point. So we put her on quinolones, aminoglycosides, and linezolid, which are the IV formulations available. And we actually chose to give meropenem also when she had peritonitis, which will have some additional anti-TB effect as well. Even when she got better and her gut started working, we had to ensure that her gut absorb. I mean, when we could not just restart her oral ATT just because she could take oral liquids. We need to ensure that the gut absorption is good. So we had to wait for a little while before we could start oral regimen. After that, when she deteriorated, our concern was, what was her absorption? One of the questions raised was, why did we have to do first and second line drug sensitivity testing, and why did we do whole genome sequencing? The issue was, we gave her drugs when we knew the gut was not in the best situation. So how do we know if she did not develop drug resistance while on treatment? So the decision to do drug resistance testing was at that point, actually, when we sent off the genome sequencing and drug resistance testing, I believe we wanted a little bit more reassurance in terms of the drug sensitivity. And by the time actually we got the whole genome sequencing, one of the questions raised was, how can you ignore the whole genome sequencing? By the time we got the whole genome sequencing, it was several months into the treatment. By this time, the child was literally bedridden, was walking, talking, and doing much better. So we actually chose to keep the whole genome sequencing aside, even though and go clinically that she's getting better, because we are still exploring this option of genome sequencing. We don't know the quality control. We don't know how to interpret it all the time. So we had clinical improvement. We had the DST testing done. So that's the reason why we just chose, let's just wait on the whole genome sequencing. Let's not change the treatment when she's getting better to a second line, to complicated drug resistant test. Unfortunately, we were proven right in that decision-making process because several months now, she's so much better. She's gained what, like 10 significant weight, in weight and height, and she's it's a pleasure to see the child when she comes back for follow-up at this point. So yeah, it was a good decision, is what we thought at the end of the day.
Definitely, ma'am, it was a good decision and the patient is improving and clinical decision is I say is best. We have Dr. Puri sir with us from NITRD. He has some questions. Sir, please.
A comment. The comment is that prevention is better than cure. So what I have seen in my practice, that most of the patients who we are treating in MDR, they were started as drug sensitive TB, even in the program. And later on they deteriorate, they develop problems, and then they are admitted with MDR wards. And when I look through their reports and through their history, then there is somewhere, there is a deviation from the standard of the TB
So
care.
sorry to interrupt, but your voice is not clear.
So this is a comment. Comment is that prevention is better than cure. So whatever I am seeing here in the MDR ward, most of the patients they develop who were drug sensitive, they develop MDR TB. When I go through their record and the history, I found that there is somewhere there is a deviation from the standard of the TB care. And the most common deviation I observe that the CBNAT is done and if sensitive is done and the patient is put on the treatment and nobody bothers to do the LPA or nobody bothers to do the LPA direct or the indirect. Indirect means if the sputum is negative, they should subject it to the culture. And for the culture, they should do the LPA. So if the culture is negative, then it is all right. But at least our effort should be there to do the drug sensitivity which are available in the program. At least rifampicin and INH drug sensitivity should be done for each and every case. And if you see and you analyze your own cases, you will be finding that we are lacking. So my suggestion is that LPA should be done, and if sputum is negative, similarly midget should be done. What I do is that I send the patient's sputum after CBNAT if it is sensitive for midget culture, and our lab first they do the smear. If smear is positive, they do the LPA. If smear is negative, they do the midget, and from the midget they do the culture. So this is my suggestion. We should follow these guidelines and prevent the emergence of the MDR. As our learned speaker, Dr. Rajendra Prasad, our teacher, he is always saying that it is a man-made disease. So MDR is a man-made. We should prevent the development of MDR. Thank you.
Thank you, sir. Any more questions from the audience? So I think we are done with the questions. We can move to our national expert opinion. Dr. Bhera sir, please give your opinion.
Yes, very good afternoon, ladies and gentlemen. Very interesting case and very interesting comments given by very senior people. You know, that is exactly what happens to a clinician. We face with such problems day in and day out. I'll just, without going any specificities, I'll just make 2 or 3 general points. I think as already been highlighted by Jai Kishan, by Dr. Puri, and also by Professor Rajendra Prasad to some extent. You know, I think we should follow, there is an algorithm, they are done with the much thought out things. You see here, we are trying to tell, we could do the LPA, the second line LPA, we could go for whole genome sequencing, but we have deviated from the path of the directive or whatever this thing. We have never done the LPA, the first line LPA. I think that is one mistake. I am very blunt about that. That should have been done. All, no excuse of the family did not want. I don't know
If the family is agreeing for LPA 2, what about the first line LPA? Why they will not agree? Yes, you may say, as Dr. Puri said, if it was a smear positive, but here it was smear positive. You got the gastric lavage, it was positive. Then only we went for the other things. And then also, I did not get the report, you never told. You did the midget, you said the growth of mycobacteria. But what about their sensitivity? Follow that, or maybe I missed that part. I am not very sure whether I missed that part or not, but I'm sure I got your point telling that there was growth of mycobacteria on midget, but you did not tell us what is the DST. So why I am emphasizing on that part? Because that is the gold standard. If you have got something in the DST on the midget, so forget about your whole genome sequencing and XYZ. Now, the second point is, I'll just make one comment about, obviously we all agree as clinicians, when nothing is allowed orally, how to give the, the anti-TB drugs. Unfortunately, most of the drugs are oral. The injectable drugs, whatever was available, I think you did the right thing. Maybe I would have done the same thing. I support Professor Rajendra Prasad about that part. Although such things are always having the issue of resistance to those drugs which are used. But I think very rightly, once the oral feed was accepted or acceptable, then you changed over to oral, and that is the way I would have done, and that is the right thing. But my only other issue is the cycloserine. I did not know, you made a comment that first thing, the patient had got already seizures. So you should be careful about using cycloserine in a patient who has got already seizure. You should have been careful. That's what I'm trying to say. And secondly, the why cycloserine was given for some time and then it was withdrawn. I don't know what is the logic of giving cycloserine, because it has got good penetration. Are you going to continue it for a long time, or just 2 weeks of cycloserine? I don't understand the logic of adding cycloserine to this regimen. Maybe I was not very clear. The third thing about the steroid, I think you see steroid, what was the indication of steroid here? Then I will have, yes, if you are thinking it was a, some people still think about if you give steroid in a case of pericardial effusion, or obviously here there is a CNS tuberculosis. So there is every justification. But just telling indication of steroid for any disseminated TB, unless the patient, so adrenal insufficiency is there, patient is hypertension. So I don't think any disseminated TB, when more than the one organ is in uncontiguous organ is involved, just because of that we give steroid. That is not true. But here I think you gave the steroid before even diagnosing it was CNS TB. So I was not very clear about that logic. Maybe you may be, correct if you have thought of about pericardial TB and you have given steroid that some people give. So that may be okay, but I will have some reservation. Then the last point about the whole genome sequencing. You see, the point is now you are in a fix. First, you have any time whenever we order any investigation, we have to know that how to use it. And if something like this it has come, so now you tell you do not know how to interpret it. Now you cannot say the whole genome sequencing. What is the authenticity of whole genome sequencing? It is not yet, it's still a research tool. It has got a lot of bioinformatics come. Who has interpreted that? It is just not a simple printout comes out. You see the discrepancy. Here the gene expert is saying rifampicin sensitive, but your an LPA is telling it is fluoroquinolone resistance, but your whole genome sequencing is telling they are all resistant. So that is which one to accept. Therefore, when you are ordering any test, we must be very, very clear. Is whole genome sequencing a recommended method of making a usual ordinary diagnosis? Yes, I understand you. I think Madam at the end told that yes, when the child was not improving. Maybe you tried at that time, then why are you forgetting that? If you have asked for something, then you have to accept it. Then you have to believe that. Which actually, so in that sense, what I'm trying to say, don't go after funny, fancy things. If you don't, if you have got, you cannot follow it, then why to order something? So that will be only my strong of things when we'll be in a fix. Because technically, ethically, legally, now you may be asked. This is a case if you are doing, you have ordered some test, and now unless you prove that that particular lab has their method, has their laboratory, is the accredited one, do the test properly. Thyrocare, maybe it may be any care. I don't care about that, whoever it may be. But the question here is, we are in a fix. We have ordered it. So I do not have even an answer to that. So my answer, simple answer will be that, yes, I have got the gene expert, I have got the LPA2, they are time tested things. So why should order a thing which should not have come? Then I think at the end, I should say overall, the question, of course, here, I think very rightly, Madam explained that they have tried to find out a contact tracing from where this, this disease came. Maybe they did not find anybody. So obviously the role of TPT and the role of prophylaxis therapy, particularly in children, of course, in this case, we cannot blame that it was not given or it should have been given, but that is, I think, one point we should keep in mind. Then the last but the least, I should say the involvement of multiple specialties. Here you see, I think so many, the pediatric surgeons were involved, the pediatricians were involved, microbiologists were involved, and all other departments they were involved. So, so in that sense, except my strong objection about not following the protocol, not following the algorithm, diagnostic algorithm, I should say the case is very well managed. And once the patient is improving with the first line drugs, that should have been stuck to, and that very rightly at the end you have stuck to that. And I'm sure the patient will do well. The only thing come here will be how long are you going to treat the patient? What is the plan of the unit? I am sure they are going beyond the usual 6 months or 9 months. Maybe they will be treating this patient little longer. But anyway, in any case, that is acceptable. That should be left to the clinician and to the group. So, so I should say overall it is a very, very interesting case that highlights the various uses, and I should say the abuses and the limitation. I should not say abuse with the due excuse. I should say the limitation of various laboratory tests. I think we should still, there is some role of clinical judgment, as Dr. Rajendra Prasad said. Thank you, Dr. Singla. I have to say this much.
Thank you, sir. Thank you so much for your opinion and for your comments. So before closing the session, I would like to hear Dr. Singla sir's opinion on this case. Sir, please.
Thank you, Dr. Saroj. I think this is a very challenging and difficult case involving the multiple organs, and the way child presented and the way child progressed, initially having multiple organ involvement of pleura, pericardium, abdomen, and not being able to take oral drugs, and required, they were even thinking of the subacute intestinal obstruction or even perforation. So oral drugs could not be given at that time. If you have the diagnosis of tuberculosis in mind, I think only injectable drugs option is there, which I feel rightly they have done. That is, they chose the injection in the form of imicacin, linezolid, and levofloxacin. These are the only injections which are available in our country. So they have done that, and senior people like Dr. Behra, Dr. Rajendra Prasad, Dr. Jayakishan, I think that way it has also been said by them that at that time there was no choice. Only thing is, whenever I feel that if you are considering steroids in a case, suspected case of TB, one must assure that patient is on proper anti-TB drugs. Otherwise, if there is a case of TB, and not on adequate treatment for TB, then steroids can be counterproductive. So that also, but at that time they did not have any the DST available with them, so they had to go empirically. And somebody raised the question of why steroids were started late. You see, their primary diagnosis was Klebsiella sepsis, and the TB was low down in the list of the differential diagnosis. So that was the reason. Initially, they did not started steroids early; they started little late. But one thing definitely, which everybody has pointed out, is that we should follow the national guidelines. That whenever you have a sample, besides gene expert, please subject it to first an LPA, second an LP, and culture. And if culture is positive, then again it should be subjected to LPA. Maybe I think what I can gather is being in the private sector, the LPA were not easily available to them free of cost. So for that, they could have linked up with the local IRS with the help of the district TB officers so that it could have been arranged free of cost and the benefit could have been given to the child. Because whole genome sequencing is still in our country, the program has not accepted this. There are quality control issues. So in case you spend money on the whole genome sequencing and then the report comes which is not as per your expectation, not as per your clinical outcome of the patient, and you are not responding to that, then one doesn't know how to go about it. Dr. Behra has already talked in detail about this, so I will not be further emphasizing on this point. Then regarding the drugs, patient also had CNS involvement in the second episode. So once you have a CNS involvement and regarding the NTB drugs, somebody has asked also in the chat box. So drugs like injection, amikacin, streptomycin, kanamycin, the pyrazinamide, ethionamide, they are also good drugs. Linezolid, cycloserine, they also cross the blood-brain barrier well. The drugs like ethambutol and PAS, they do not cross the blood-brain barrier well, so they should not be relied upon. Then drugs like good drugs like bedaquiline, delamanid, and clofazimine, their CNS penetration is still largely not clearly known, but there are some case studies which have shown that bedaquiline, delamanid, clofazimine, they can be good drugs in case they are required. So they can be considered in such cases. So we should know which are the drugs which cross the blood-brain barrier well and which do not cross the blood-brain barrier well. They should not be chosen. So overall, I think this was a very challenging case involving the multiple organs. And even there was an issue once the second episode occurred, whether it was iris or it was a case of drug resistance. So they did consider both the possibilities. And we should keep in mind that iris usually occurs early. If it has to happen, iris will occur usually in the initial 4 to 6 to 8 weeks. If it is occurring late, then unlikely to be iris, more likely to be non-response to treatment. In that case, either drug resistance or poor absorption of the drugs. Unfortunately, in our country, such a big country, and this point has been highlighted through this clinic many a times, that we should have facilities for measuring the blood levels. It's called therapeutic drug monitoring for the anti-TB drugs, more easily available, so that whenever we are thinking that the person is not absorbing the drugs, this test can be performed and we can know whether we are thinking on the right lines or not. If DDG sir, Dr. Joshi is there, I request once again with the folded hands that we should make the availability of this test more and more easily available in more and more centers across the country. So that would really help in the clinical management of the patient. So once again, I thank the Telangana team, all the chest physician, the ID specialists, the gastroenterologists, the surgeons who could manage this case very well, and anything that ends well is well. And ultimately, the child is surviving, child is improving and gaining weight. So that is the end of the treatment outcome, and we are happy about it. And really, we thank them for sharing such an interesting case. There are many ifs and buts which appear later on, but once you are facing the issue, in that case, we know the difficulties with the clinicians they face, but they could take it along, and today the child is doing well. Thank you once again. Thank you.
Thank you, sir. There's a feedback link shared in the directory. It will help us to further improve this clinic and to be useful to each one of us. So please give your feedback. Is the link is already shared in your chat. So with this, we come to the closing remarks. I'll request Dr. Ashok Bhardwaj to please give his closing, to give the closing remarks for the session. Sir, please.
So thank you, Neeta, thank you, Rupak. So am I audible?
Yes, sir. You are audible.
Yeah. So thank you very much. So I am sorry I could not participate in the full course because we had a meeting in Shimla with the principal. So, but I initially listened, and the summary which was given by you, Vinita madam. So the experts meant given by Dr. Behra, Dr. Rajinder Prasad, Dr. Jackishan, and in the end, Dr. Rupak and Dr. Puri also. So I fully agree with those comments. So, but I will request here that we should, because there have been guidelines from time to time, 2016, 2020, 21. So we should follow the guideline. The algorithm which are there in the guideline, they are self-explanatory. So I don't comment on the treatment given to this patient, but I stress that we should follow the guidelines, and the algorithms which are there, they will lead us to a positive conclusion. So thank you very much. I'm sorry there were not attendance was very less today, 240. It never crossed 240. So we have to do something for this attendance. So I will take serious concern in future for this. So thank you, Nita. Thank you, Rupak, for giving me a chance. Thank
you, sir. Thanks a lot.
So with this, we end this session. Once again, I'm repeating, please give your feedback in the chat box. Link is there in your chat box. Please give your feedback. Thank you so much. And a very good day to everyone.